We're live.
We're live. All right, great. Good morning, everybody. It is 11 o'clock. I think we'll give one more minute for folks to get into the room, and then we'll get started.
Sounds good.
And Michael, just as a technical issue, where can I see the folks that are in the room? I know typically there's something on the right-hand side.
It should say attendees on the top right.
Okay, I don't see that on my
I
view.
see it, yeah. I see Alfred, Caroline, Jen.
Okay, you know what? I think it's okay. Let's help you. All right. We'll give it another 30 seconds or so, and then we'll jump in. Oh, participants. There we go. Okay, great. All right, let's get started. Good morning, everybody. My name is Jamie Blaustein. I'm the CEO and co-founder of the Sylvia Brafman Mental Health Center. Welcome to our third roundtable. We're looking to do this every month. This is number 3. The first 2, if you were on, if you remember, was all about a good guide to treatment. We did part 1 and part 2. Today, we're going to be talking about ethics and boundaries, and I will be facilitating, and the main event is Ben Brafman, the Chief Clinical Officer of the Sylvia Brafman Mental Health Center and the co-founder as well. So welcome, Ben. And
thank you, Jamie.
Welcome to everybody who's on and who's still joining. A little bit of housekeeping up front. So yes, this is a CEU event, and you guys will all receive your CEU credits over email from Michael Grossman within 2 weeks. This is primarily, like I said, going to be the Ben show. Ben's going to present for, I don't know, about 45 to 60 minutes, most likely. And then that will be followed by Q&A at the end. So I think we'll wrap up likely 12:15 to 12:30. If you have any questions, feel free to put your questions in the Q&A feature on the webinar. It's okay if you put them in as Ben is talking. We'll get to it at the end. But sometimes it's just easier to throw it in there as soon as you think of it versus remember it later. Also, if you could please put in where you're from in the chat, which I can't see right now, but I'm sure I'll figure it out soon enough. We always like this to be interactive, and so it's always great to find out where people are dialing in from. And then lastly, as far as housekeeping, we will send this presentation around after, as well as some other information on the Sylvia Brafman Mental Health Center. So, like I said, the first 2 roundtables were a little bit more interactive. It was sort of a, still more Ben than me, but more of a conversation. This is going to be more lecture style. I may chime in, but frankly, I want you guys to hear from the expert on this. And yeah, looking forward to hearing some of the questions at the end. So let us get started. Ben,
Fantastic.
Perhaps you can share the presentation. I want to just give a little bit of an intro, and I apologize to those who were at the first 2 and have heard this little spiel of mine. But I want to just give folks a little bit of context as far as who Ben is and who we as the Sylvia Brafman Mental Health Center are. So here's the 2-minute version. So I am, like I said, Jamie Blaustein. I'm from New Jersey. I do remember that there's a lot of New Jersey and Pennsylvania and New York on these Zooms typically. So welcome to everybody from the Northeast. Ben and I are hail from the Northeast ourselves. Ben from upstate New York, me from New Jersey originally, like I said. I was a really good kid growing up, no major issues, very ambitious, good grades, a lot of friends. Went to the University of Michigan for undergrad. Things got very bad very quickly for me. That pretty much kicked off a 7-year nightmare of rehabs and psych ER visits and overdoses and arrests and all of the insanity that I know many of you are familiar with from a clinical perspective. So I start going to treatment centers, and my fourth rehab was a place called Destination Hope in Fort Lauderdale. That's where I met Ben. Ben was the founder, the clinical director, really everything, CEO. He actually kicked me out of rehab. I was a very bad boy. I was not ready to do what I needed to get better, but he planted some seeds. And a couple years later, at 24, I finally waved the white flag and surrendered. And that kicked off an amazing journey. Christmas Day of 2013, I got clean and sober, coming up on 11 years. And I got really, really into mental wellness, recovery, different modalities, and really was on sort of a quest to figure out what is my optimal wellness package. And so Ben and I go our separate ways, never planned to be in behavioral health. I was very blessed to just, again, get 100% invested in recovery. And the results of that was an internal shift. And then the result of that was all these external blessings really came to fruition. And that's typically how it works. When we get good internally, the world starts to cooperate with us. And so I go to Duke, I get my MBA, I go to Wall Street. I was an investment banker in New York City. And then about 3 years ago, coming up on maybe 3.5, 4 actually, Ben reached out to me. He said, "Hey, I want to do something that is primary mental health. Do you want to be involved?" I sold Destination Hope, and I really want a primary mental health / true dual diagnosis treatment center. I had no plan on leaving my job or New York. I told my mom in New Jersey what I was considering doing. She immediately said, "Do not do that. You're 30 minutes away from me in New York. You've got this great job." I then told her who it was with, Ben, and she immediately forwarded emails from like 2, 3 years after I'd gotten kicked out of Destination Hope, where Ben was checking in, wanted to see how I was doing. That meant a lot to my mom because it meant that obviously his heart was in the right place. But beyond that, she remembered that clinically he was exceptional, way beyond any of the 7 treatment centers that I had been in. And so I had mom's blessing. I moved down here to Florida. I live in Miami, and our center is just outside of Fort Lauderdale. And Ben and I coming together was really a perfect match in the sense that he is really, really comfortable in the trenches with patients, with families, navigating everything that is clinical. I'm not clinical. I like business. I'm good at it, I think. But I'm a patient advocate because of my own journey. And so us coming together was really a nice sort of complementary match. And we've been really doing great work for patients and families ever since. And so we really want to have like an intellectual capital angle to everything that we do. And that is part of the rationale for the Roundtable. We want to be able to work with folks in the space to talk about topics like the one that we are today. And we're really grateful to have everybody on the Zoom today. Ben, maybe you can share a little bit about yourself and flip.
Sure.
We'll send this around after.
Absolutely. Jamie, thank you for the introduction. Before I formally introduce myself, a fun fact, and Jamie, you're responsible for this. 3 years ago, September 13th, we had our ribbon cutting. It's the reminder came up on social media, so everybody wants to check that out. And there are no coincidences. One of the things that I was attracted to partner up with you is the ethical code that you demanded. Behavioral health gets a black eye in a lot of ways, and bringing somebody in with your business acumen with with your strong ethics was essential for me as a business owner and as somebody that really wanted, and not only do I want to own something, but I wanted to like do what I love to do. So having that and then being able to talk about it today in more detail about ethics and boundaries and all of that, it sort of all comes together. But yeah, three years ago today, we had our ribbon cutting, which is fantastic. I mean that's amazing.
Awesome. Yeah, and
Yeah.
Ben, just a little bit of, a minute or so. I want to get to the core stuff here, but
Yeah.
yeah.
Absolutely. So Ben Brafman, as Jamie said, I am a licensed mental health counselor, a master certified addiction professional. I have a dual master's in counseling and marriage and family therapy. I am a board certified supervisor for the state of Florida and several other states in the country for people and folks that want to get licensed. I teach, I supervise. I deal with families directly, strategize, and run all the clinical operations at the Sylvia Brafman program. I feel like I've done everything in behavioral health from the bottom to the top, from being a behavioral health tech / nurse aide up to owning my own businesses over the years. And Sylvia Brafman is no different. So that's who I am in a nutshell. Thank you everyone for joining us today, and we're gonna get right into the presentation of ethics and boundaries
Yeah,
in
and
treat.
Ben, sorry to cut you off. I just want to ask one question because I think it's always important to understand the why. Why are we talking about what we're talking about and the context? Why is this an important topic, and why is it that you chose to talk about this for the third roundtable?
I appreciate you asking that. This is a topic that's near and dear to my heart. The reason that I feel it's important is that it's an area that's not spoken about a lot, but weighs very heavily on the day-to-day operations and things that we do. It's a guiding light for us when there's chaos, when there's confusion, when you don't know what to do. When you fall back on ethics and you fall back on boundaries, it gives you an edge. It gives you a professionalism that maybe some of your peers don't have. And also from a layperson wouldn't understand. And it differentiates you from your patient or your group or your treatment center, and therefore it makes it much more formal. It's really the professional piece that makes the difference between having a casual conversation with somebody in your living room or at a restaurant versus you're sitting down with someone. You have a professional standard, you're following it, you're trained, and you're able to help them. And so that's a big reason why, Jamie, that I want to do this presentation, and I want to share these slides, and I want to share my hope, strength, and experience.
Really appreciate that. So why don't you jump into it? What are ethics and boundaries, and then
So
yeah.
yeah, so I'm gonna go through these slides. I'm gonna spend some time on some of them and not so much time on the other ones. But I will tell you that I will spend a lot of time on boundaries. Boundaries really makes up the difference between everything, and it's really, you'll see through my lecture how boundaries really is going to guide you to be an ethical, professional person with morals and having a sense of right and wrong. So anyway, so let's define ethics and boundaries. Ethics are a moral standard by which people judge and behave. Where do they come from? They come from the laws that we have. They come from the natural things that are in society right now. An example is, why do we stop at a red light? Why do we stop at a stop sign? Because that's the law, that's the right thing. And there's people that blow through stop signs and blow through red lights. And when that happens, the chances of bad things happening really occur. Code of ethics defines the standards of expected behavior for members of the profession. So in that sense, it gives you the structure that you need, and it gives you the identity of, okay, now I know what I'm supposed to be doing versus what I'm really not sure which way to go with this. Ethics are based on moral values, a sense of what is right and wrong. Many of you have that, you have that intuition in you. You have that your intuition, your stomach is flaring up or doing flips. You should listen to that intuition more times than not. It's guiding you. And so you have these moral dilemmas, and it's attached to this ethical code. And there is where you have to make some decisions. And we're going to get into some examples. I've got some personal examples that I'm going to share with everyone that'll add more color to all of this. What's a boundary? Boundary is the line between self of the client, self of the worker. In a later slide, I'm gonna be very clear about how to divide that up. What you are versus what you definitely are not. Boundaries provide a system of limit setting. It holds the ethics that we have in place. That's what's so critical about boundaries. A boundary is the framework within which the worker-client relationship occurs. Okay, let's go to slide number 2. Why talk about boundaries? And I said I was going to spend a little time on it. Increases well-being of the worker, reduces client anxiety as rules and roles are clear. Remember this, that when you have boundaries, you are giving structure to a patient. You're providing them with a direction. Many times patients that we see, regardless of setting, they don't have boundaries. Their boundaries are so skewed and so unstructured that that's one of the main reasons why they're in therapy or in treatment, because their anxiety is so high, or they're depressed because they can't accomplish anything, or something else is going on. It gives them a clear and cut role and a direction on what to do. It also reduces risk of client exploitation, which I'm going to talk about, provides role model for clients, promotes a productive, positive workplace. Let me just talk about exploitation for a minute as I go to the next the next slide. There's a thing in our industry called informed consent. It's one of the most ethical things that we can do for our patients and our families, is to share with them what informed consent is. And that is basically, you are telling the patient exactly what you're going to do before you do it. So for example, many of you have gone to doctor's offices and you're going to do a procedure, and you have to, sir, you have to fill this out, right? And at the bottom it tells, well, let me explain to you that we're going to do this procedure, but here are the things that could happen. And they're pretty severe, right? And so, but they 99.9% of the time, they don't happen, but they could. That's informed consent, is that you're explaining to the patient exactly what you're doing, exactly why you're doing it, what the consequences will be, both positive and negative, and what's the benefit of it. And so it can't just be, yeah, we're going to do the CBT technique and we'll see what happens. You're not to fly by the seat of your pants. You are to share with patients exactly what you're doing, from EMDR to hypnosis to diagnosing them and developing a treatment plan based on some type of diagnosis. All of that stuff needs to be upfront. More concepts of boundaries: a sense of personal identity. and a self-definition that has consistency and cohesion over time, again, all related to structure. It remains constant. The boundaries are constant, regardless of emotional ups and downs. So this is very important. If you don't have boundaries, then someone who is bipolar, someone who is not regulated emotionally, is going to take advantage of that. They're going to manipulate. They're going to fall back on their old behavior, especially if you don't have structure. Structure is, what am I allowed to do within this box, within this framework? What am I allowed to do? What am I not allowed to do? The framework within which the worker-client relationship occurs. It provides a system of limit setting, as I shared with you. The line between the self of the client and self of the worker. Again, all about the boundary, all about the structure. Who negotiates boundaries? The worker, the therapist, the professional is ultimately responsible for managing boundary issues. Duty of the worker to act in the best interest of the client or patient. And then, of course, workplace policy, which leads me to my first example. So one of the first experiences that I ever had in setting boundaries was I was actually an intern, and I worked for the United Way. And I was doing private practice, and as an intern, you see patients and all of that. And one particular night, it was 8 o'clock at night, and I was seeing a female patient, and I had been seeing her for about half a dozen times. And she came in at 8 o'clock at night, and she was an attractive young lady, and she had a mini skirt on. And she starts to tell me about a dream that she had the night before. And as she's telling me this, she starts to cry and put her head down and say things like, all I need is a hug. I dreamt of you, and you're my savior. And if you hug me, everything will be fine. And then she ups the ante by spreading her legs, by trying to maneuver her body closer to me. And she just kept saying to me, I want a hug, I want a hug. So I stopped and I said, I don't hug. And I said, in fact, the workplace policy is there is no touching patients. And she immediately switched on me and jumped up and said, you're the worst POS there ever was, I hate you, and basically ran out of the building. She was a borderline. I know many of you have dealt with borderlines, but as an intern, you can imagine this was one of my first patients ever, and I fell back on the workplace policy. I was nervous. I wasn't sure what to do. There was no one else in the building, 8, 9 o'clock at night. In fact, just a little leftover from that, when I left the building at about 9:30, I had eyes in the back of my head. I didn't know what to expect at that point. But that's a real situation where I literally just fell back on the workplace policy, and I kept it completely professional. I didn't even engage in anything other than that, because I felt even then as an intern, if I did, I was really going down a slippery slope, which I'll talk about later. But again, that is an example of, you can get into some serious trouble quickly. You can be in some unethical dilemmas if you allow yourself to be. So simply use the workplace policy, move along. Why is the onus to understand this on the worker? Worker is the professional. Client may not be aware of the need for boundaries or able to defend themselves against boundary violations. Remember this, that's why the patients are there. Their thinking is messed up. Their thinking is disorganized. That's, in essence, if I could define therapy in one sentence, it's to unravel disorganized thinking for an individual or a family. If I could just get right to it, and that speaks to boundaries, that speaks to the emotional irregularity. And so it's on us as professionals to maintain those boundaries at all times. there is an inherent power imbalance between worker and client. And the worker is perceived as having power and control. There is a story I read in the New York Times related to power and control between a professional and a patient. There was a young woman who was in therapy her whole life, and she went to go see this renowned psychiatrist in New York City. And she finally gets an appointment with him, and she gets there, and he's at his desk, and and it's a stereotypical psychiatric office with a couch and leather, and probably the head of a buffalo on the wall or whatever, and books all over the place. And the psychiatrist turns just to like make a note in his file, and he turns back, and the woman is lying naked on his couch. And he says to her, "What are you doing?" And she says, "Aren't we doing therapy?" And to her, therapy was sex with a professional. And she needed to unwind all of that. Those boundaries, those skewed, crazy boundaries needed to be unwound, and she really needed a lot of help. But that's the extreme. That's what could happen when this power imbalance takes control. So relationships help determine boundaries. There's personal relationships that you all have, and there's professional relationships that you all have. This is a good rule, and it's a good slide of not what to do with your. Don't do this with your spouse, your significant other, your friends. When you have a personal relationship, the relationship is limitless, right? It could go in any direction. I'm sure many of you have friends that you've got friends from grade school and middle school and high school that you could talk to once a year. You're still friends. Or you have people that you see every day. It's limitless. You're perceived to be equals. There's no money involved. There's mutual gain. There's mutually agreed upon levels of intimacy. Unlimited time frame, as I just suggested, about how long you know the person. Time doesn't really define a friendship or a relationship. It's really what you do with that time. And then there are no code of ethics. So that's the line, right? And now you go into the professional part of it, and the professional boundary, it has limits and it has boundaries. There's only a certain amount of things that you're able to do. There is a power differential. The person is coming to you for help, and you're a perceived expert, and there is an expectation that you're going to behave in a certain way. No physical intimacy whatsoever. I know that there are codes out there that say, after a year or after 2 years, you can become friends or engage in a relation. No, my rule is once a patient, always a patient. Do not go down that road. That's a disaster waiting to happen. There are rules of confidentiality. Someone comes to you and they share their deep, dark secrets. That's important. That's real. And if you're sharing their information with other people casually, you're not professional and you're being unethical. Scheduled interaction, right? It's not just come whenever, call whenever. Again, that sets up the boundaries for you as a professional, as for them. Document everything, legally define roles, and of course, a code of ethics. Documentation. Let me just say a word about this. I know this is a clinician's Achilles heel. You hate it, but you have to do it. If you didn't document it, it didn't happen. And you should think about who is reading your notes. Who is reading your notes is the following: your supervisor, an attorney, the prosecution, your peers, your boss. Those are the chart auditor, ACA, Joint Commission, Department of Children and Family, or whatever you call it in the state that you're in. That's who's reading your notes. And so you want to get it right, and you want to take credit for the good things that you do. Again, just be ethical.
Ben, can I
Let's
ask
see.
a question?
Clear boundary. Sure.
So, the examples you gave seem pretty universal. Like, those are extreme examples that will stand the test of time. In 100 years from now, they will still be unethical and they will still cross boundaries. But do you think that the standards with respect to boundaries and ethics change over time as society changes? I think especially in the last 10 years or so, there's been increasing sensitivity around certain social issues. Um, I guess the question really underlying that is who is the arbiter of ethics and boundaries? So have you seen a shift in what that looks like?
It's a great question, and there's a constant shifting with ethics and boundaries. I'll give you an example. And so it depends where you live. Um, if you live in rural America, there's a really good chance that you're going to be friendly with someone that's supposed to be just in a professional setting. It's kind of like you're forced to. You see him at church, or you see him in the restaurant, or you see him in school because there's only 500 people in that town. That does happen. That there is that. Social media plays a massive role in ethics and boundaries. We have access to each other like we've never had before, and so in some ways you have to be even stricter and be careful and be private. But then also there's this sort of understanding in society that, generally speaking, people are like, yeah, my therapist is on social, he's on Instagram, but I'm not going to friend him here. I'm not going to blow him up. Like, there's sort of that understanding. And so when it gets like a little skewed, it's something that you gotta be aware of. So it is a little bit different in today's society versus, say, even 10 years ago.
It's funny you say that. We actually did a podcast with my therapist. And as a result of that, like, I think I had to follow her Instagram in order to like share it with her.
Right.
And I noticed she didn't follow me back, and my ego was hurt. I was offended. I was like, what the hell? She didn't follow me back. And then I realized, oh, okay, yeah, she doesn't
Yes.
want, she's establishing that boundary. So I will commend her for doing a good job with that.
Yes, it's a line. Like, for example, I'm not sure that I would have done the podcast, but that's me. It's not unethical.
Sure.
It's just that's the line.
Sure.
And she had a line in the sand, which I think is fair. And I don't think we know yet all the ramifications of all the social media that's going on and how it's truly impacting us yet. Things are so sensationalized now, that we'll learn as we go. But yes, to your point, it's not cookie cutter exact. If you live in New York City, it's the same as it would be in Arkansas, in a rural country, village in Arkansas. It's not the same. The boundaries are slightly different. Here are some clear boundary areas. Planning social activities with clients, don't do that. And the key word there is planning social activities with clients. Romantic and sexual relationships, don't do that. That's a big no-no. Having family members or friends as clients, I know that's tempting for some of you, but really just don't do that. A client should not be your lover, relative, employee or employer, instructor, business partner, or friend. Again, you got to be very, very careful with all of that, and understand what your role is. Areas where boundaries may blur: self-disclosure. I'm going to loop back to that one. Giving or receiving gifts, another one I need to get back to. Dual or overlapping relationships, becoming friends, physical contact. Refrain from gossip. Never say something you wouldn't want heard or repeated. Again, some of those are pretty common sense wise. Let's talk about self-disclosure for a moment. So I think that self-disclosure is acceptable. I think the timing of self-disclosure is the key to the whole thing. And I think that what you share is critical. I'll give you an example. Is a lot of folks in treatment and therapy are also in recovery. And recovery is very personal. Recovery and treatment or recovery and therapy are not synonymous. They're two separate entities, and they should remain that way. However, if you're a professional and you're also in recovery and you're practicing your recovering principles, I don't think it's out of bounds at some point to share that with your patient, whether they're in recovery or not. I think that has value. I think that if you come out of the gate strong and the first session is you're discussing your recovery with a person, I don't think that's appropriate. I think you should take a wait and see, because it is personal to you, and you earn that, and let's see what the patient does as a patient. Are they able to critically think? Are they able to follow directions and set goals before you start to share some of the things that you've gone through personally? But I think that self-disclosure thing is a tricky one. There are professionals out there, they're colleagues of mine, that will say yes to self-disclosure, and it doesn't really matter. Some will be a little bit more conservative, and there are some that say never. Never disclose anything about yourself. And the key is this: whatever you pick, stick with it as a professional. If you're not going to self-disclose, don't self-disclose. Don't say I'm not self-disclosing, and then all of a sudden you vomit on the patient and the family and you share everything. That's not okay. Pick a side and go with it. It depends on what you're sharing, and also for the professional, it's intent. Why are you sharing this information?
Yeah.
And a lot of young therapists, what they do is they share about themselves to build trust artificially. And they don't have enough tools in their toolbox, and they don't allow time to do their thing. So let me tell them I'm in recovery, because that will gain trust. But the fact is that 6 sessions down the road, the patient's going to go, this guy's got nothing for me. I don't care if he is in recovery. I don't want what he has. And it's going to implode anyway. So be careful with that stuff. Giving and receiving significant gifts. I'm okay with that to a degree. I've been offered all kinds of gifts. I've been offered football tickets. I've been offered travel, plane tickets to travel. I've been offered all of that. I wouldn't accept those things. What I would accept is a card. I would accept if somebody has made me food. I don't remember if I ate it or not. I probably didn't, but I would accept that. Small gifts, that type of thing. If it's significant, if it's large, you got to make it part of therapy. You got to have a conversation about it. Why are you giving me tickets to go to this, to go to the Super Bowl? Like, what is that about? Why are you sending me to Hawaii? What is that? So those are all things that need to be talked about. But a good rule of thumb is, if a card is good, and you can establish that in the beginning. And then a lot of this is common sense in terms of the blurred boundaries. Danger zones, over identification with the client, strong attraction to the client's personality, strong physical attraction to the clients who can potentially reward you with their influence, transference and countertransference. Really, this slide is all about transference and countertransference. So when you are attracted to a patient, it is not abnormal. Don't think that something's wrong with you, but that is a clear indicator that you need to go talk to your supervisor. You need to go talk to a colleague hash it out. Why are you attracted to this person? Why are you attracted to their personality or physically? We're physically and emotionally attracted to people all the time. It doesn't mean that you're going to act on it, but in therapy, how is it going to impact you as a professional? And you've got to get to the bottom of that, because if you don't, the chances of you acting on those impulses, it increases. Okay. So transference and countertransference. Transference, a redirection of clients' feelings from a significant person to the therapist. A transfer of past feelings, conflicts, and attitudes into present relationships or situations. Countertransference involves the same principles, except the direction of the transference is reversed. The counselor's feelings towards a client. This is probably the number one thing that I deal with in supervision with the therapist that I supervise is transference and countertransference. A lot of times therapists can't see things that a supervisor can or an outside person can because they're too close to it, because they're experiencing this type of transference. Physical boundaries: maintain proper physical distance. Do not touch clients do not touch clients in an inappropriate manner or one that can be misconstrued. Boundaries are unique to each person. Don't just assume. When in doubt, ask. Don't just hug somebody. Ask them if that's acceptable. Questions to ask in examining potential boundary issues. This is important. Is this in my client's best interest? Whose needs are being served right now? How would I feel telling a colleague about this? How would this be viewed by the client's family or significant other? Does the client mean something special to me? Am I taking advantage of the client? Does this action benefit me rather than the client? Am I spending more time with the client than others? Here's the dangerous part about unethical behavior, and these questions speak directly to the following. Once the answer is either yes, I'm going to act on these questions, or I'm going to ignore the answer, you're entering into a slippery slope that it's almost impossible to come back from. Don't kid yourself and fool yourself that it's a one-off. I'm going to sleep with this patient. I'm going to have a good time, and then I'll be good. That's it. Like I just get it out of my system. It's cool. The circumstances are right. Doesn't work that way. Once you go down that road, you're going to continue going down that road, and it never changes. And that is very sad. I'm going to share another example of a professional that went down this road and they never came back. Years ago, I supervised a doctor. She got her MD from South America, and she was a licensed social worker in the United States. She was a fantastic clinician, very, very bright, and patients liked her. And it turned out that she ended up seeing patients from the treatment center that I formerly owned privately in her home. So that was the first thing, right? The second thing is that it was a heck of a coincidence that these patients were all cash pays. They were all wealthy patients, right? And so I got wind of it, and I met with her in my office, and I was hoping against hope that she would tell me and prove to me that what I had heard was completely false. Unfortunately, nothing could be further from the truth. She was not only seeing these patients, they were paying her cash. She was seeing them at her home in her living room. All of that stuff is unethical. I mean, there's all kinds of problems with that. So my first question was, did you think about whether or not if a patient showed up and they had a slip and fall, and they hurt themselves, how would you handle that? And she said to me very casually, no, I've never really thought about that. That just won't happen. Okay. So there's that. And then I asked her, did you think about the fact that these aren't your patients? And she looked at me and she said, I don't know what you mean. And I said, well, these are this treatment center's patients, and the only reason you have these patients is because of somebody else's hard work. Again, unethical. And she turns to me and she says, here's what I know, Ben. What I know is that I know you have a problem with this. I don't have a problem with this. And it was at that point when I knew that this highly credentialed, she was an MD, med school. She went to her master's program, got licensed. She had no clue what it meant to be ethical. And I fired her immediately, and got her out of there, and all of that. I'm not sure if I reported her to the board or not. I don't remember. Certainly I had grounds to, but that is a very dangerous thing. And the reason that I shared that story with you is that this was no dummy. This was a well-educated, well-read, highly credentialed, highly respected individual that could give a crap about the ethics or codes that we follow. And it really is problematic, and it's troubling. And once you go down this road, you're not coming back. That is a fact, that you will stay that way, perhaps for your whole career. Okay. Exploitation stems from the inherent power, the differential and the ability we have to exert influence over the client, the use of professional relationships to promote or advance our emotional, financial, sexual, and religious and personal needs. Of course, all of that. Closer look at exploitation. Client may actually initiate and be gratified by the exploitation. They may enjoy feeling special, can be subtle and vary from promoting excessive dependency to avoid confrontation because we enjoy the adoration of our clients. So, for example, if many of you are finding yourselves texting with your client or your patient, or taking calls at all hours of the night, something is not right. Okay, that boundary is not okay. That's something within you that needs to be looked at, and you need supervision for that. We all need boundaries, right? If for nothing else, you need a break. Okay. Risk of client exploitation increases in dual relationships. Of course it does. You shouldn't be friends. You shouldn't be lovers. Teacher, student, all that stuff, employer, employee. It becomes very blurry and very incestuous. Okay. Not all client interactions are dual relationships. So this is similar to what Jamie was talking about, but running into a client at a social event, you're running into a client at a social event. Like you normalize the situation. You don't have to like, avoid or run away. Some people that are in AA or NA may see a client or a patient in a meeting. If nothing else, it's good role modeling. Good. You're practicing what you preach. Good for you. You're taking care of yourself. Your client is your waiter at a restaurant. It does happen. It might be a little awkward or strange, but nothing unethical about it. How you participate in the interaction will determine the outcome. Exactly. A lot of common sense. If you're shame-based and you're weird about it, you're going to make the patient uncomfortable. If you storm out of the restaurant or whatever, I mean, that to me is just a lot of common sense. Okay. Some dual relationships are unavoidable. You and your client belong to the same church or synagogue. A client lives in your neighborhood. Your agency hires clients as staff or utilizes clients as volunteers. Again, it all depends on demographics, socioeconomic status, where you live in the country. I mean, social media also, sure, I should probably add a slide on social media that, you know, that short circuits a lot of things. So we have that. Okay, let's go to the next one. Dealing with unavoidable dual relationships. Open and honest discussion with client on the nature of your relationship. Separate functions by location. Be aware of threats to confidentiality. Understand your role as a professional. So, for example, I'll go to separate functions by location. Sometimes if you're a professional, and I'll use recovery as an example because it's a good one because it happens a lot. Let's say you go to a meeting and you see a patient or a patient's there. Sometimes you might have to change the meeting for a little while just to maintain that boundary so that you don't, you're not talking to the patient constantly at work or in recovery. You need your own time. Okay, let's go to the next one. Minimizing risk of exploitation and boundary crossing. Be alert to potential or actual conflicts of interest. Maintain supervision or consultation relationships. Be aware that isolation is often a major factor in ethical violations. What does that mean? That means that if you are tempted by someone and you are not seeking assistance as a professional and you're isolating, you're more inclined to act on those impulses. Talk to somebody. If you're having feelings for a patient, other than some very minimal, I feel sad for them or whatever, more like love interest or whatever, you need to seek out a supervisor. And believe me, it works. Picking up that phone and talking to a colleague, it works. That's why, in part, what we do, because we got to look out for each other. These are sick patients that will want to exploit. They'll want to have drama. They'll want things to be chaotic. Meet your personal needs in other areas of your life. That's a work-life balance. Jamie, I know you talk about that all the time as a CEO, is having a wellness package for yourself. And I think that clinicians need to incorporate that into therapy, and patients need to take that much more seriously, especially in this day and age. Exercising and meditating and yoga and education and medication, whatever works. Relationship should focus on client at all times. That's a very true statement. A clear and understanding of ethics and attention to professional boundaries. If your therapy sessions are a therapy session about you and the patient, something is wrong. That's not your time for therapy. And I know that it sounds strange, but that's just not ethical. And there's too many therapists that practice that. Okay. It's never a good idea to ignore a situation or interaction, just hoping it will all work out. If you are unsure if a situation was a boundary violation, consult with your supervisor. Respect the individual characteristics of the client, such as culture and social identity, appearance, sexual orientation, religious affiliation, age, talents, and skills. Let me share with you another example of this third one. Years ago, I was treating an Indian family, and the daughter was very westernized, where the parents were not. They were very old school, and she was running out at night, and she got a tattoo, and she was dating, and she was smoking marijuana, and doing all the lovely things that the Western culture teaches us. And so we went through it, and I made the clinical mistake of joining with the identified patient, which was the daughter, trying to just boost her up and have her have a voice. and the parents felt they felt slighted. You know, they felt, I guess, if I'm being honest, violated in some ways, like they didn't get their needs met, and they felt ashamed. They felt ashamed as parents, and I felt at the time that I contributed to that, and they left. The session ended, and they left, but how they left made me pause. As they're leaving my office, the mother looks at me and she says, "Is there a back exit to your building?" And I said, "Yeah, go over here, go down, and they left out of the back, basically the back door, privately, shamefully. And I never forgot that, and it propelled me to look further into cultural details of things. I I don't think I did anything unethical in that scenario. That was a poor clinical judgment. My point is that respecting people's culture and how you perform therapy with that culture is extremely critical to the success. And that also speaks to something that Jamie alluded to in this day and age, where we have a identity crisis, of gender, of sexual orientation. And if you're ignorant to it, if you're not educated, I don't care if you agree with it or not. That's separate, and that's something that you need to deal with in supervision. But be aware of it and be educated to it, so that the patient feels safe. And it was that experience where the family, the parents especially, they didn't feel safe with me. And to me, it was a poor clinical judgment that I would have done better. But when she looked at me and she said, "Is there a back way out of here?" I was like, wow. I got some work to do, and that really stuck with me. It made me a better clinician after that. Jamie, that's all I have for the slides. I hope that got the job done. I covered a lot of stuff. I feel like I could have spent another hour or two or three on this.
No, I think it was perfect, Ben. Nice and concise yet powerful. So thank you very much. I guess I'll ask you for any closing thoughts at the end. For now, though, like I said, I'd like to go to Q&A. Doesn't look like we have many. There's one. Michael, I'm not sure who actually submitted this because I think it's coming in under your name, but it's more of a comment. It says, same experience, female tested positive for UA. She was facing 2+ years for a BOP, violation of parole. Crying, stating, "I will do anything if you do not report me." I thought for a minute and said, "Yes, you can stop using drugs." I thought she was going to hit me. So a comment, but nonetheless, definitely aligned with some stuff that you were talking about, Ben.
Absolutely.
Yeah.
Yeah.
Go ahead.
No, go ahead. No, go ahead.
If anyone has any questions, now would be a great time to throw it in the Q&A feature. Would you be willing to have a class at my
We have a couple more comments in the chat if you want to read them.
comments? Yeah. So good idea. And while I'm doing that, if anybody, here we go. We got one from
Okay.
Caroline.
Oh, yeah, there it is.
So Caroline asks, and I think Caroline's in New Jersey. Yeah, that's what I remember seeing, but I could be wrong. Yes, she is. Do you think the role of peer recovery specialist confuses clients regarding boundaries with clinicians?
Yes. I do sometimes. I think role confusion is a big one out there. I think case management, peer specialist, therapist, even the terms therapist versus counselor, I think that all gets confusing to the patient. I think that further education is needed. That's that informed consent, that I like to talk about, where the patient is clear. Sometimes the patient is going to need, they're gonna need repetition, and constant reminder of, no, that's not what a peer specialist does. That's what your therapist does. At Sylvia Brafman, Jamie, in with the clinicians. It happens all the time. You know, that we need to, you know, we to kind of guide them back. But yes, it definitely speaks to role confusion, and that is the responsibility of the professionals to make sure they're clear with the patient and family what I can and can't do.
Excellent. Thank you for that. Just a couple of things here. Somebody mentioned they were late and they were able to get the majority of the presentation. Will the slides be available? Yes, they will be. We're going to send slides around and we're going to send some more information, and we will also send the CU information within the next 2 weeks. Okay. So next question, should therapists handle money in a facility? That's interesting. I guess maybe Ben, because I'm more on the business side, I'll chime in on that. I think there's a difference between an outpatient practice. And I think if you're self-employed, you know, I wouldn't say you need to hire somebody specifically to collect. I think, you know, probably not, but I have no experience with an outpatient practice. I'd say at a center like ours, so let's call it the intensive outpatient, PHP, residential, and obviously a hospital, anything above outpatient, absolutely not. I mean, I always say this to Ben, right? Sometimes there's a scenario where, say, the insurance is going to cut the patient off, or whatever the nuances are. A conversation on extension of treatment needs to happen. I always say clinical drives financial. I'm not going to have somebody call and have a conversation on money if we're not even clear on what the clinical outlook is and what the recommendation is on length of stay, how much more time will that look like, etc. So Ben is constantly, you know, there's sort of a our director of operations is between Ben and I, Valeska, and she will often, you know, we'll see that there's some financial issue, and I'll always say, hey, get Ben or the clinician or both on a call with the family, give your outlook, give what your recommendation is, and then that naturally should feed into what is the financial ask if there is one. And so, yeah, I think they should be kept separate, but I do think that sometimes there needs to be a convergence between those two conversations, and therapists should stick at what they do and what they're focused on and what they're good at, and really ignore the impact of money as long as they can. But sometimes the two parties need to be aligned and sort of be a united front when entering that financial conversation.
For sure. And let me just speak to the private practice piece of it. Yes, the therapist should handle their own money if necessary. If they have an office manager, that's fine. But I also think that not enough is done to educate up and coming clinicians about the finances or the insurance impact of private practice, or even further getting into intensive outpatient, which is why I do encourage everyone to experience handling their finances and handling the money as it comes in, so you learn the business aspect of it. And I'm talking separately from what Jamie just said. I'm really talking more about if you're interested in private practice.
Right. Question, what are the main ingredients to a consent form? And this person is in Florida. So maybe Ben, you know, I could probably, if I dig into some emails and look at our consent forms, speak more to like the legal, you know, nuances and all that. But maybe Ben, you could just speak.
Yeah, I mean, a consent form is you know, who the consent is for, what are the demographics, the address, the phone number, email, all of that. What is the consent for? Is it for full disclosure? Is it for something specific? Make sure signatures are on there, make sure dates are on there, and then there's a limitation. Consent forms, I think, are usually a year. You know, they're good for a year or 6 months, and that's just something that you would come up with. But just know who you're sharing this information to, why you're sharing it with them, and make sure it goes to the right area.
Question from Alfred Jones. Hey, Alfred, good to see you here. If a professional knows a client personally, so church member, YMCA member, family member, before treatment, what is the best way to address and set boundaries with client and family without offending the client and family?
I think that happens more than we like to admit. And the way that I have handled it is the truth. And the truth is that there's almost like there's a line in the sand. And you help the family. Let's say you even go to the house and you have a sit down with the family, and the patient's going to go into treatment. There's a line in the sand that you share with the family. You say, listen, on this side, I'm here at the house. You see me at church, it's okay. When your loved one enters into treatment, I have to take a step back personally. I have to, because I have to maintain my professionalism, and I have to maintain, the code of ethics. And so know that if I'm behaving that way, it's not personal. Nothing happened. I don't dislike you. It's that I am a professional. I'm trying to help you in the best way possible. And by maintaining these boundaries, that's exactly what I'm doing.
Mm.
That you can absolutely share with the families. They will love it. They will respect it. And then it'll be on you to follow it.
Another question in a similar vein, I think the same theme in terms of some sort of personal relationship, sort of an adjacent one with somebody that could be a prospective client. The question is, when a boss refers their family or friends to you for therapy, how would you navigate this boundary with the boss?
Don't do it. I think that's some murky waters right there. And if I'm hearing that question correctly, you work for someone, they have a family member in trouble, and they refer their family member to you. And I'm thinking of it in terms of like private practice, right? Like that kind of thing. That's murky waters. That being said, there are times when in treatment centers where there have been family, friends, and all of that have come in, again, boundaries. If you're gonna do it, set up the boundaries. Talk to your boss, talk to the family members, set the expectations. Because if you don't, it's going to be the Wild West. But if you do, and you want to, if you go in it with eyes wide open, know what you're getting yourself into, and navigate it appropriately. That's the best I could. That if you're going to do it right. The best thing to do is not do it at all.
Bunch more coming in. I just want to make a comment that we really love connecting with therapists in different parts of the country, learning more about their practice, being able to communicate, what we do, and also just talk shop, clinical and business, everything. So if anybody on here would be interested in that, we would love to hop on a Zoom with you, get to know you better. Please feel free to reach out to us. Ben and I really love getting on Zooms with folks. So just want to say that before we continue to churn through these questions here. The question is, when transporting a patient, do you think there should be a second person involved in the transport?
When transporting a patient, I'm going to say that if you should never transport a patient in your own car, or personally, or in an Uber with the patient, ever. You should not do that. If you're talking about treatment centers or hospitals, I don't think you need extra escort. It would be fine just to have, the treatment center or hospital transport the patient. But you should never be in a situation where you yourself are transporting the patient.
Yeah, and I think from my perspective, just watching you do your thing, Ben, oftentimes you're getting on the phone with the patient prior to admission, or you're reading the pre-admission screens and the medical records, and you never. There may have been some times where, based on what you've read, you do want to send some extra support. but it's very uncommon. I think maybe if you see
Yeah.
something in particular that would give you reason to believe there could be a boundary issue, you would maybe be nimble and make an adjustment on the fly, but that's not the
Right.
status quo.
Right.
Okay. AA is not evidence-based. Should it be part of a residential treatment program?
It
Go ahead, Ben.
It depends. It depends on what your philosophy is and what the culture is of your residential program. Here are the facts. The facts is that AA and NA and those self-help groups help millions of people, not only in the United States, but around the world. It's amazing. It's not just the steps, but it's the themes behind the steps. It's the people. It's the action that takes place, and it's the group itself. So yes, I'll always incorporate AA in any treatment setting that I'm ever associated with because it works. And
I just want to say too, Ben, that it's important to differentiate, what are you trying to be everything to everyone? Because we see a lot of
that's right.
people, actually not people, but facilities, especially down here in Florida, that are really set up to be a true drug rehab. And yet they market as though they're a mental health center as well. And if you go to the website, you see substance use on the left, mental health on the right. And really what they mean is, we'd like you to admit and we'd like to bang your insurance policy for some treatment, but they're really not set up to deal with primary mental health diagnoses. And so I just want to say, I don't know what again, I'm a lay person, I'm not clinical. So I don't know what the threshold is for evidence-based. But I can tell you, I have plenty of anecdotal evidence, my own life being one piece of evidence, that AA does move the needle for those that are true addicts, alcoholics. If you have what I have, the physical compulsion, the mental obsession, we'll call it spiritual malady, and you are an addict alcoholic, then yeah, it doesn't mean it will necessarily work 100% of the time, but I can tell you that is really the thing that moved the needle for me getting better and hundreds of other people that I know. So we do want to incorporate it to the extent that the person is an addict alcoholic, even if it's a dual diagnosis patient, to varying degrees, of course. Okay. When you are supervising substance use disorder counselor interns, what code of ethics would you use?
So I would use the code of ethics from the Florida. We're in Florida, but the Florida Certification Board, and also my code of ethics as a licensed professional. It's a combination, and there's a lot of overlap. It's pretty much the same thing. So that's the code of ethics that I would use.
I had a boss who was unethical, referred friends that they would refer to me, hired a former client of hers. I reported to licensure board, nothing happened. How do we navigate things like this in a system that doesn't necessarily weed out supervisors like this?
Well, I'd probably need to know a little more about, when they say that nothing happened, and then the details of what the boss actually did, what the violation was. Maybe it was determined they didn't do anything. I don't know, but if I'm them, I would call the governing board that they filed the complaint with and speak to someone about the next steps that they could take.
Yeah, the comment I think is from the same one that asked the question: insurance fraud, hiring former clients, supervising her best friends, etc. Okay. So we've got a comment: find another job. So Ben, I hope that you don't do that, and I hope that we didn't offend somebody too much. I don't think
Thank
you're
you.
going anywhere.
I want to be the general manager of the New York Giants.
You know, I think they may have been talking about me, to be honest. So I'll start looking.
Well,
And then
we talked
another
about
one.
you being a talk show host.
Yeah, yep, true. Co-occurring capable. Okay. So there are no more questions in the
There
chat.
are some in the chat, Jamie.
In the chat, right?
You
But
want me,
not
you want
not
me
in the
to read them?
Q&A.
Yeah.
Okay.
Like
So
they put their questions in the chat instead of the Q&A, a couple
yeah,
people.
no, I think okay. So what could be a potential example to also establish boundaries for interactions with possible home health aides, caregivers for the individual, with the patient, also like a health aide for the disabled slash elderly population. And this person is not a therapist, but a special ed teacher. So what interactions with possible. So
Well, what's the
essentially,
question?
people, you know, the ancillary folks in the patient's life, what those boundaries should look like. I guess you can almost say it's sort of a colleague or a co-worker, you know, type situation.
Yeah, I mean those, those are important roles, and just because those types of roles don't warrant a huge salary doesn't make them any less valuable or any less unethical. And in fact, they have direct lines sometimes to the patients where they can be unethical. I would hold them to a very high standard, the same standard that I have, or that a clinician would have. Just use that as sort of a guide.
Right. Okay. I think okay. How did both of you navigate this business relationship and that Jamie and Ben had a clinical relationship in the past? It's actually a good question. So I was 21 when I met Ben. He, like I said, kicked me out of treatment. The only point of contact between Ben and I in that 12-year period was really two things. One, when I would vacation in Florida, reach out to him and ask if I could speak to the patients. Again, super involved in AA and all sorts of things with regard to mental wellness, and it was just sort of part of my natural service work. So we had really established like a friendship, like from a distance, and like I guess however you want to, however you want to characterize that. We had some engagement that was not patient staff member and was sort of, unique in that sense. So I don't know, Ben, did any thought go through your mind when you reached out, or did you sort of feel like the patient staff relationship had sort of expired at that point?
Yeah, you had gone on to other things. You had maintained, long-term, sobriety at that point. You had gotten your life together, and yeah, I think I think that if let's say you were in trouble during, let's say 3 years ago, you were in trouble and you needed treatment. I don't think that I would have if I had a treatment center, I think I would have, if I knew, I probably would have referred you somewhere at that point and not been directly involved. Just because that it sort of expired for me. And you had started living your life. So
Yeah.
there was definitely those boundaries in place. And you maintain them as well.
Sure. It's also worth noting that you were my direct provider. I think you had
That
entered the picture here and there when I was truly struggling, but
that
you were
that
not
is
my
no,
direct.
that is a good point. That's absolutely true. And I could argue too that I worked really more with your family than I did with you,
Yeah,
which was critical.
absolutely. All right, well, I think we're gonna shut it down here. This was awesome. Ben, thank you so much. Really, and any closing thoughts on your end before we formally wrap it up?
I think that, yes, I just think that regardless of what setting you're in, private practice, outpatient, inpatient, hospital, is to find time to discuss ethics and boundaries. Just have conversations, build it into your discussion with supervisors or group supervision or however the format is, but bake it into your monthly meetings. It's really essential. And unfortunately, the only time that this really gets news is when something bad happens. And by then it's already too late. You're being reactive instead of proactive. So
Yeah.
so talk about it.
Excellent. Well, thank you everybody once again for joining. Really, really grateful. We're going to do another one next month. Michael, thank you for facilitating. Again, we really love to reach out to or connect with each and every one of you outside of this roundtable. And Michael will follow up with both the deck as well as the CU credits. And hope everybody has a great weekend.